Dear colleagues, it's a great pleasure to be with you today. And during this short presentation, I'll be happy to discuss with you SIP and the ICD11. There are many opportunities and perspectives in Europe and certainly in Portugal for improving quality of pain management and especially for chronic pain. I'm the chair of SIP Europe. In fact, I'm the co-chair, of course, because with Pain Alliance Europe and Nadia Maliou, the president of Pain Alliance Europe, and Lisa Jutila, the vice president, that has been more than a pleasure, an honor, a real honor to run SIP during the last few years. We'll discuss different aspects of SIP, but in the particular context of ICD11, and why is that, first of all you know that prevalence of pain is unacceptably high. We need to improve that. We need first to better understand that, but we need then to have an impact on that, to make it more manageable for people living with pain. And for that, we first have to have good definition of what chronic pain is about. ICD11 offers that kind of unified definition, which considers chronic pain as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. That's the International Association for the Study of Pain definition of pain. But for chronic pain, it's when it persists for longer than 3 months. Pain, and that's absolutely essential, is multifactorial and multidimensional. There are biological aspects, psychological, and social factors that contribute to the pain syndrome, but obviously pain has many consequences on people's quality of life, and that has consequences as well. So all we know this biopsychosocial model of pain guiding the biopsychosocial approach, which is about looking at potential tissue damage, knowledge and understanding about medicine and different treatment, coping skills and expectations to try to help people living with pain better manage it. But it's absolutely essential also, the last point on the left part of the slide, to improve healthcare system responsiveness. This is not good enough in our Western world countries. We need to improve that and to help people better cope with daily activities, improve their quality of life, and really feeling supported despite the fact that they may have pain that cannot be entirely solved. There are different types of pain, and the ICD11 classifies the diagnosis by considering at primary or secondary pain syndromes. And this MG30 chronic pain list and chapter is the big step, the big jump that ICD11 has proposed in comparison with ICD10. This is really something that's absolutely essential to understand, and that's my first point during this presentation, is that should guide all the definitions of pain in our research project, but also in our education or educational programs. And finally, in terms of data collection, where we deliver care, to be sure that it's appropriately classified, documented, and recognized. So then you immediately understand a key component of the why do we need to implement it. To facilitate report diagnosis. Of course, if it's not appropriately documented, it simply doesn't exist. And that's again not acceptable. We need to be sure that we have the resources when we know that evidence-based treatments exist to improve the quality of life of people living with pain. Data collection for that can help at the individual basis, at the system level and at the global level as well. We need to better understand the epidemiology of pain and how it changes over time. That helps and that will help support health services through the digitalization of healthcare, but also through the digitalization of the healthcare related data in general, because this information is absolutely essential. When we speak about costs, it's not always that simple to understand exactly what we are speaking about, and the interpretation can be difficult. If we were going to have better data, it would be much easier to decision makers to understand the magnitude, the importance of the burden of pain, and how we can better support people living with it, but also people delivering care. Again, if it can't be coded, it doesn't exist. That has been well discussed in the literature. Now we need to implement it. So what are we speaking about when we speak about implementations? So SIPP has engaged from years to make the implementation possible. That started with very concrete exercises like amending the regulations of the European Health Data Space, and thanks to MEP Sokol and different people at the European level, it has been possible then to integrate in the European Health Data Space European Parliament report. I mentioned that the latest classification of the ICD should be used. So in our case, the ICD11, which is supposedly the latest one and the last one, because that will be a dynamic one that will be improved over time. So the ICD11 with the new chapter on pain that I have previously detailed is the one that should be used. And in terms of data interoperability, encompassing the different dimension of treatment and the different dimension of health-related issues, and in particular pain, we're going to have much better data in the future. So that's what we are speaking about. So the two amendments have been integrated, and this is a snapshot of what we have finally obtained, that we should make use of the ICD codes where applicable. By the way, it's going further than just in the European Health Data Space, but last year, the United Kingdom government decided to align the regulation of health data capture on the classification used by the European Health Data Space. So again, the ICD, and in particular the ICD11, which is a big progress in terms of quality of the data regarding pain, painful conditions, and pain treatment. So that's about harmonization, interoperability, and quality of the data. But now, because health is delegated to the national entities, national government, we need now to make it work. And that's why it's important for SIPP Portugal, it's important for the SIPP national platforms, and then we continue to invest time and energy to make it actually implemented at the national level. That goes with this position paper with a number of clear recommendations, and I will go on a number of these, but these are these recommendations have important implications regarding delivering care, but also in terms of research and education, as I've said before. So with that, we have a number, not only the position paper, but a number of educational material. So you can use this leaflet, and you can continue then to promote the use of ICD-11 through different routes, different stakeholders, That's not that simple. I will detail some of the obstacles, but also some of the solutions. But it's important to keep that high on the agenda. So how could we do that concretely? So I cannot say exactly how SIPPT Portugal and how Portugal should do that, but I know that a number of solutions have been identified in different countries and through different organizations. First, let's look at the obstacles that we have identified in the recent literature and the recent publications that were available. And there was an important meeting last year organized by the WHO describing some of these obstacles first, and then I will go on the barriers and the opportunities and solutions. Technical obstacles, yes, let's not neglect that. IT systems, compatibility, legacy systems not supporting the ICD-11 structure, registry adaptations are clearly enormous efforts. Knowledge obstacles. How many of our teams and team members actually know how to code, even though we know that ICD-11 is much easier to learn and to practice and to use that ICD-10. There are good publications on that, but the complexity is not that simple, and post-coordination codes are very useful to capture the multidimensionality of pain and distress and interference, but that needs learning. Organizational obstacles, complex governance structure. When we go to our different organizations, it's even potentially difficult to understand exactly who will decide and who will define the strategy, making ICD-11 implementable, given the gap with the ICD-10 structure, but even also given the lack of preparedness of the different national agencies. That requires a lot of effort in terms of communications. Let's not underestimate that. So these are the different obstacles that have been described by these different countries, and you can find out more in the references during this WHO meeting. But what about the barriers? There are policy and legal barriers. That's not that simple. Structural barriers, timeline, misalignment with international aspects, steering committees, all the dependency on our quite heavy structures, and technical barriers, interoperability gaps that I have already mentioned, but that are also relevant on the technical point of view. However, there are facilitators and solutions. Let's look first at the facilitators who could help us. At the governance level, even though we have difficulties, there are national steering committees that have been set up in some countries that have proven very useful. So let's consider that. And that's where SIPPT national platforms may clearly have a role, especially when the role and responsibilities are well defined. That can help, and there are good examples, and Sweden may be one of the good examples, facilitating the communication. That's also very useful. Training is absolutely essential, and that can be specific training for ICD-11. That can be training also in advocacy in general, like offered by SIPPT, but also by other organizations, and it depends on the exact target and what people want to push. Workshops, exercises, meetings, all that can be useful and facilitate ICD 11 implementation. What we are doing today, international collaboration, that's excellent. And with that, we can exchange information. There are also transnational collaboration, and the example is, so the good example is the one in Scandinavia, cited on this slide. Concretely, the solutions can be found at technical level by piloting projects, and there are some good examples in different countries, but they will be different depending on the different type of project. For instance, in my own research program, I have implemented or embedded the ICD11 classification when documenting pain diagnosis in studies. We have to find what's the best way depending on the local technicalities, but that's important to consider that. It's technically not difficult, but it needs to be piloted and then implemented. Organizational solutions, roadmaps have been shown to be a useful national stakeholders consultation meeting, and that kind of organizational solutions with clear governance structures have helped to progressively find how to plan the agenda and make it work. Training solutions that I have already mentioned in terms of facilitators, but that's clearly a win-win, because then if people can be trained not only for the ICD11, that can also help federate a network, and in particular, a network interested in patient-centered care, and pain is definitely a type of condition that requires patient-centered care more than others. Communication solutions, campaigns, papers, communication platforms, including the tools that I have mentioned before, like the leaflet, all that can be potentially very useful for implementing the ICD11. So, all in all, not saying that it's easy, I have mentioned different opportunities and perspectives. I encourage you to go now or later on your preferred browser and just to type ICD11 and then to look at the ICD11 browser to see how easy it is, how you can implement it as a patient organization to better communicate and use the right terms, find the right solutions. And if you're an healthcare professional, of course, to improve communication with patients, communication with decision makers, communication with your students. If you use it in your research programs, I thank you very much and wish you a good meeting.